Hi, this is Dr. Taylor with Taylor Made Integrative Therapy. I just wanted to talk today about the importance of posture and the function of the upper extremity. So the upper extremity is composed of the shoulder, the arm, elbow, wrist, and hand, and is very mobile, making it susceptible to injury. It requires a dynamically stable base of support for it to function properly. What do we mean by dynamically stable? Well, it must have proper mobility and be able to resist forces that act upon it. That base is made up of the scapular shoulder blade and the spine. So let's take a quick overview of the spine, then take a closer look at the scapula. The adult spine is composed of 26 bones, 24 vertebrae, a sacrum, and a coccyx. Each vertebrae is separated by an intervertebral disc that provides shock absorption and increased mobility. The vertebrae are divided into three regions, the cervicals, thoracics, and lumbars. You can see the cervical and lumbar regions are extension curves, also known as lordotic curves. They are not present at birth and develop as babies develop extensor tone and learn to stand up erect. Since we live in such a flexor-based society, these curves begin to reverse and it puts strain on our discs. That's why most herniations are in the neck and low back. Now the thoracic region is a kyphotic or flexion curve because it is present at birth. Typically we see overflexion or hypokyphosis in the thoracic region, which we will show puts not only the rest of our spine at a disadvantage, but the rest of our upper extremity as well. Now let's learn a little anatomy with the scapula. It's a uniquely shaped, large flat bone that is curved so it can rest on the rib cage, forming a pseudo-joint called the scapulothoracic joint. It doesn't have a capsule or ligaments, but for all intents and purposes is a joint. The scapula also has a bony spine called the acromion that attaches to the clavicle to form the acromioclavicular joint, or the AC joint. There is a small socket called the glenoid where, along with the head of the humerus, forms the glenohumeral or shoulder joint. One role of the scapula is to properly position the upper extremity in static posture and dynamic motion. As you lift your shoulder, the scapula must upwardly rotate so the ball has a socket to rest upon. It also provides a base for muscular attachment, 17 muscles to be exact, including the rotator cuff. And it transfers energy from proximal to distal through its connective chain. The ability to function well relies on a combination of alignment, movement, and dynamic stability. If the shoulder blade doesn't start out optimally, then it's difficult to end optimally aligned. The shoulder blade must have a certain amount of movement in all planes or the shoulder joint will compensate with excessive movement and early degeneration or injury. The shoulder blade must also be dynamically stable. If it does not maintain its position during upward or downward movement, the rotator cuff muscles have to overstabilize the joint and they will not last long with repetition or heavy load. So here's a picture of proper scapular alignment. You can see the top of the scapula should be around T2 and the lower inferior angle around T7, meaning it's not too anteriorly tilted. The superior angle should be closer to the spine than the inferior angle, meaning it has a slight upward rotation. And the scapula should be resting flush on the ribcage and not winging off. Here's a picture of poor scapular alignment. You can see the superior angle and inferior angle are both higher than they should be, showing an anterior tilt. The superior angle is farther from the spine than the inferior angle, so it's downwardly rotated, and the shoulder blade is not flush on the rib cage. Again, we call that scapular winging, which shows the shoulder blade is not dynamically stable and won't be able to resist force. That puts the stabilizing pressure on the shoulder itself. So here we have a picture of the muscles that move the shoulder blade and the proper alignment and overhead motion of the shoulder blade. So overhead motion of the scapula requires the shoulder blade to upwardly rotate, protract, and posteriorly tilt. If you start in poor scapular alignment with downward rotation and anterior tilt, like in the previous slide, you probably won't finish where you need to. Now let's look at the muscles on the left here that act on the shoulder blade. So upward rotation is achieved mainly by the serratus anterior and the upper trapezius muscles. Protraction is performed mainly by the serratus anterior and the posterior tilt by the lower trap fibers. So imagine the shoulder blade didn't rotate up enough. You'll have to compensate in the shoulder itself with excessive motion or somewhere else in the spine. Now let's take a look at the subacromial space of the shoulder joint because this is where many shoulder injuries occur. So this space has the acromion as its roof and the humeral head as its base. The subacromial space is not really space at all, as you can see. It is completely filled with the rotator cuff muscles, the bursae, and the tendons. Improper scapular positioning and movement can decrease this space. So the rotator cuff muscles' main purpose is to keep the humerus centered in the middle of the joint during movement. When proper centration of the shoulder joint is not maintained, most often we see an upward translation of the humeral head into the subacromial space, creating shoulder impingement. You can see this in B in our picture down below. So this impingement will cause pain and inflammation of the rotator cuff, further weakening its ability to centrate the joint. It's a self-perpetuating cycle, and until we address the underlying cause of the impingement, the shoulder will continue to worsen. So in this slide, we have an MRI of the subacromial space when the shoulder blade is tilted back versus tilted forward. The tilted forward image on the right is indicative of someone with poor posture and rounded shoulders. The picture on the left with the posterior tilt is upright posture with the shoulder tilted back. So you can see it's a significant difference in that subacromial space. You can see how just starting with good posture decreases the chances of shoulder impingement. As a demonstration, if you sit in a slouch posture in your chair and do nothing but try to lift your arm over your head, you won't be able to lift it as high, and some might feel a pinch in their shoulder as well. So when we have proper alignment of the shoulder blade, the muscles of the rotator cuff can work together to stabilize the shoulder and keep it centered as on the left. When you have poor posture and rounded shoulders, we see the presentation on the right with internal rotation and posterior translation of the humeral head. That creates a shortened subscapularis and lengthened infraspinatus, putting the subscapularis at a mechanical advantage. With the rounded postures we see all over the place, it's no wonder everyone has weak posterior rotator cuff musculature. And over time, this will lead to degeneration of the shoulder joint, causing uneven wear on the cartilage and bone spurs. So let's look at some of the research. We have 30 published articles reviewed showing decreased upward rotation, posterior tilt, and external rotation in subjects with shoulder impingement. People that develop shoulder pain have significantly less upward rotation at 45 and 90 degrees of elevation, and an increase in internal rotation and decrease in upward rotation leads to greater internal impingement in overhead athletes. Including scapular exercises in shoulder impingement patients significantly improves outcomes. So you can clearly see what we want to happen with the shoulder blade. We need that upward rotation, posterior tilt, and external rotation of the shoulder when we go overhead. And then obviously we have to look at the scapula and not just the shoulder when we're trying to rehab. So here's our typical postural adaptation we see. We live in such an anteriorly driven world, from sitting at work to driving in our cars or looking at our cell phones and tablets, that we get stuck in this very flexor dominant posture. Below we see Yanda's upper cross syndrome, which is only a two-dimensional representation of the human body, but it's still very valid. You can see with the forward head posture, rounded shoulders, and rounded upper back, the anterior tilted shoulder blades, that there are muscle imbalances. There is weakness and over-lengthening of the deep neck flexors and the lower traps and serratus anterior. The pec major and minor are tight in the front, and the upper trap and levator scap are tight in the back. So you can't just work on one area like the lower traps and try to strengthen them up. You have to address all of these factors along with proper spinal posture to completely resolve issues. This slide shows the different angles of scapular alignment on the thorax. If there's too much flexion or extension, too much lateral flexion or rotation, it will impact the scapular alignment. So it's important to address thoracic asymmetries when looking at upper extremity injuries. So here's some research regarding good posture, and especially related to the thoracic area. So upright posture significantly increases acromio-humeral distance. So just sitting upright will increase the subacromial space and reduce shoulder impingement. The typical person needs 13 to 15 degrees of thoracic extension for full overhead elevation. Now, if you're already starting in 5 or 10 degrees more of thoracic flexion, you're going to need even more thoracic extension to overcome. The thoracic hyperkyphosis is correlated to loss of shoulder flexion and abduction, a little repetitive. And then the last one, a slouched seated posture reduces shoulder full can strength by 16% and flexion by 18 degrees. So not just range of motion, but poor posture affects your strength, obviously detrimentally. All right, so here's thoracic manipulation. This is what we do at TMI therapy. We always adjust the spine first, but you can see here these two research articles show that manipulating the thoracics resulted in decreased pain and improved shoulder flexion range of motion in subjects with rotator cuff tendinopathy. It also resulted in immediate 51% reduction in pain and a 30-degree increase in shoulder elevation. So continuing down the spine, let's move into the lumbar region. If you have poor posture in the thoracic region and you're stuck in flexion, you're going to have to compensate in the lumbar area with overextension. So if your thoracic spine can't extend, you will sacrifice core engagement by extending your low back to get your arms overhead. Again, the body's really good at getting from point A to point B, but with impairment in one area, it will be at the cost of another. If you don't have good core stability because you overarch your back, your shoulders will have to try and stabilize, and they aren't nearly as strong as your core. Your shoulders, and especially the rotator cuff, will be the ones that suffer. You can see below the research in the Journal of Orthopedic Science shows a link between lumbar lordosis and shoulder pain. So now let's head back up to the cervical spine. On the right is a normal cervical spine with a natural extension curve. On the left is a reversal of that curve due to forward head posture. You can see the spinous processes here on the right have good distance between them, showing that they're in proper alignment. On the left, because of the forward head posture, the upper cervicals have gone into overextension and they're almost jamming together. They do this because it's the only way to keep our eyes level with the horizon. The problem with this is the nerves that innervate your scalp and your head come right out the base of the skull here. And with this overtension and impingement, it can cause headaches. So back over to Yanda's upper cross syndrome, we find that with forward head posture, the levator scapula and the pec minor muscles tighten, which downwardly rotate and anteriorly tilt the shoulder blade respectively. So again, with overhead motion, those are the exact opposites of what we want to happen. Now, in our clinic, we can release those muscles, but until we actually fix the forward head posture, we will continue having issues and we will continually have to release those muscles. So as you saw in the x-ray of the forward head posture, most of the loss of the cervical curve happens in the lower cervical spine, which is where most people get disc herniations. And you can see in this picture here, the nerves that innervate the muscles of the upper extremity come out from C5 to T1. If the bulging disc impinges on a nerve root or multiple roots, you can have pain, weakness, numbness, and tingling. So here we see some more research regarding the cervical spine and the upper extremity. You can see 71% of subjects with lateral elbow pain had pain in the cervical-thoracic junction, so they seem to be correlated. Manipulating the cervical spine increases pain-free grip in subjects with lateral epicondylitis. So restoring proper cervical motion and position actually increases the strength of your grip. And 54% of subjects with C6 to C7 radiculopathy had medial elbow pain. So again, the neck and the upper extremity are very closely related. So let's tie everything that we just discussed back in with this picture here. So the image on the left is really good shoulder elevation. Everything in the spine and the shoulder blade are working properly. You can see he's not an overextension in the low back here. His upper back isn't flexed. It's actually going into extension. His head is in the proper alignment and he's getting a nice tilt and upward rotation of his shoulder blade. On the right, everything is not happening. He's overextending in the low back, his rib cage is elevated, he's still really rounded in the upper back, and his head is tilted forward. And you can see that shoulder blade is not tilting back, it's stuck forward, and it's probably not upwardly rotating. So I hope in this presentation we've demonstrated the detrimental effects of poor posture on the upper extremity. An excessively rounded thoracic spine causes an anterior tilt of the shoulder blade and contributes to forward head posture and lumbar overextension. This is the opposite of the finishing position of overhead movement that has a neutral head posture, thoracic extension, anterior core stability, and posterior tilt of the scapula. Chronic poor static posture also puts the posterior rotator cuff in a constant biomechanically weak position so that it can't externally rotate the shoulder or keep it centered in the joint. This results in rotator cuff injury, shoulder impingement, and more. We've also shown the research that demonstrates proper posture and scapular alignment affect not just the shoulder, strength, range of motion, but the elbow and the hand and the grippers as well. So by addressing the spine and proper posture, many injuries resolve on their own without any other intervention needed. If we only address the area of pain, it may never fully resolve. With spinal adjustments and appropriate posture exercise, we can increase mobility, strength, and stability of the upper extremity. I hope this presentation explains why we are working on your spine and posture and not just your injury. If you have any questions about your treatment protocol or about the presentation, please ask at your next appointment. Thank you very much.